So, following tissue injury or irritation, enzyme called phospholipase A2 is released, which converts phospholipids in the cell membrane into arachidonic acid. Now, arachidonic acid is the substrate for two major enzymes, the cyclo-oxigenase, abbreviated as COX, and 5-lipoxygenase, abbreviated as 5-LOX. In this lecture, we're going to focus just on the cyclo-oxigenase pathway. Now, the COX enzyme exists in different forms, two of which are COX-1 and COX-2. The first one, COX-1 isoform, is expressed constantly throughout the body, and it's primarily responsible for production of thromboxane and prostaglandins, which stimulate normal body functions, such as secretion of protective gastric mucus, regulation of gastric acid, promotion of platelet aggregation, and maintenance of renal blood flow. Now, on the other hand, COX-2 isoform is not expressed constantly in most tissues, but instead it is induced at sites of inflammation. So unlike COX-1, COX-2-derived prostaglandins mediate mainly inflammation, pain, and fever. Now that we discussed the role of COX enzymes in the inflammatory response, let's talk about mechanism of action of NSAIDs. So NSAIDs act primarily by inhibiting COX enzymes, which simply leads to decreased production of prostaglandins. As a result, NSAIDs produce anti-inflammatory, antipyretic, and analgesic effects. Now, based on their selectivity for COX enzymes, NSAIDs can be divided into three broad categories. First, selective COX-1 inhibitors, which include ketorolac, flurbiprofen, ketoprofen, indomethacin, and low-dose aspirin. In the second category, we have relatively non-selective COX inhibitors, which include naproxen, ibuprofen, piroxicam, and diflunisal. And finally, in the third category, we have selective COX-2 inhibitors, which include meloxicam, diclofenac, celecoxib, and etodolac. Now, this relative selectivity for the COX enzymes explains some of the differences in efficacy and safety of these NSAIDs. So the most common adverse effects of NSAIDs occur in the gastrointestinal tract. This is where COX-1-mediated production of prostaglandin E2, PGE2 for short, and prostacyclin, PGI2 for short, plays an important role in the synthesis of protective mucus as well as regulating normal gastric blood flow. This is why inhibition of COX-1 increases risk for GI bleeding and peptic ulcers. Agents that are more selective for COX-1 are associated with the highest risk. Now, the second major side effect of NSAIDs results from inhibition of COX-1-mediated production of thromboxane A2, TXA2 for short. As you may remember, thromboxane A2 promotes platelet aggregation, so decrease in its formation results in antiplatelet effect and thus increased risk of bleeding. This effect is particularly evident with the use of aspirin, which, unlike the rest of the NSAIDs, irreversibly inhibits COX-1 enzyme in platelets. Moreover, because platelets don't have nucleus, they can't make new enzyme, so aspirin-induced antiplatelet effect persists even after aspirin therapy is stopped, as it takes several days for the new platelets to replace the old ones. So again, agents with higher selectivity for COX-1 enzyme are also associated with prolonged bleeding time. Now let's discuss the third major adverse effect of NSAIDs, which results from their actions on the kidney. So renal prostaglandins, specifically E2 and I2 types, cause dilation of the renal efferent arteriole, which is important for maintaining glomerular filtration rate. That being said, under normal conditions, these prostaglandins have only minimal effect on renal perfusion. However, when kidney function becomes compromised, for example due to heart failure or old age, the production of prostaglandins becomes a significant factor in preservation of the renal blood flow. So, because NSAIDs decrease production of renal prostaglandins, they also may increase the risk of kidney injury in susceptible patients. Now, the last major adverse effect of NSAIDs that I wanted to discuss results from their actions on cardiovascular system. So while agents such as aspirin with high COX-1 selectivity can have protective cardiovascular effect due to the antiplatelet properties, agents with high COX-2 selectivity can have the opposite effect. In order to understand where this adverse effect comes from, let's take a look at the blood vessels supplying blood to the heart. So under normal conditions, we have a balanced effect between prostacyclin and thromboxane A2. Now, prostacyclin is produced mainly by COX-2 in the endothelium, and it's responsible for vasodilation and inhibition of platelet activation. On the other hand, thromboxane A2 is produced mainly by COX-1 in platelets, and it's responsible for vasoconstriction and promotion of platelet aggregation. So now, the problem arises when selective inhibition of COX-2 tips the balance in favor of thromboxane A2 formation. This makes vasoconstriction and platelet aggregation more likely to occur. This in turn leads to increased risk of cardiovascular events, including myocardial infarction and stroke.